I'm going to put on the one on the inside connected to the PowerPoint. Yeah, if it's in here, that'd be cool.
Let's get started. Okay guys, let's make a start. So, welcome to our second event on concussion, head injury, and basic life support. My name is David, I'm the president of UNSW Sports Medicine, and this is Kristen, who's our vice president. So tonight, got a lot on, as you can see there. Our first speaker, and Gardner, is sitting right here, and I'll introduce him in a second. But as you see, we've got a bit of an overview for concussion for you, then followed by a bit of a first aid giveaway, then the practical BLS and or SCAT stations. Then Dave Samra, who's an AFL medical officer and also an ex-physio, is going to give us a talk on cardiac arrest in sports fields, as well as resuscitation and concussion. And then lastly, Dr. John Orchard, the Australian cricket doctor and also past head doc for Origin, as well as rugby, as well as pretty much any sport over the on the face of the earth, to be honest. He's going to come in and give his perspective, go through some cases on concussion, and then we'll answer some of your questions. So, firstly, I just want to say a little bit for those who don't know about what Sports Medicine Society is at UNSW and what we do. So we have three main kind of goals. Firstly, to give you guys exposure to what sports medicine is as a profession and as a career. Secondly, educational events like these to broaden your medical skill set. And lastly, to show you some opportunities in terms of clinical experiences or electives or whatever they may be. So our events, do you want to maybe have a chat?
Sure. So this year we had our introduction of welcome to what is sports medicine, and then our concussion event. And then throughout the year, we've got a couple of more things coming up. We've got a nutrition-based event in July, and that's overlapping a bit more with Welfare Week, and so looking into some of the ways that you can look at nutrition within the general population as well as within the athlete population. And then further on in the year, we're doing another focusing towards more exams on shoulder anatomy and exam, and that's in October. And then we've also just throughout the year got some opportunities and things that we're getting set up. So the main focus of these is to create some databases for anyone that's interested, looking at either clinical opportunities to sit in with sports doctors or associated people, and research opportunities maybe for people that want to do ILPs in the area, and then also electives further down the track for anyone interested in sports medicine electives either within Australia or around the world.
The other thing that's super exciting is the first aid training course, and Edway will come in and have a bit of a chat with you as well. But to let you guys know first, we've actually cut it down to $50 per person. This is a qualification you can take when you're working part-time, and it involves a lot of the BLS principles that we've been talking about and practicing today. And it includes everything from CPR, fractures, dislocations, burns, all that kind of stuff. So it's great to get a leg up on that. And now, to introduce our first speaker, Dr. Andrew Gardner is a high-profile clinical neurophysiologist and director of NeuroGuard, a leading organization on sports concussion management, education, and research. He's going to be telling us a little bit about the latest research in sports concussion and its long-term effects. And he's recently published this systematic review on concussion in rugby league in the British Medical Journal, which was just last month. So without further ado, can we please introduce Dr. Andrew Gardner?
Well, first of all, I apologise for being so late. I like when people turn up on time and should be the person that is the person incredibly late, much as you might think. I want to apologise and say that I appreciate your time and that I hope that's no reflection. I know that you're all busy and hopefully you get something out of my presentation. So initially I was given a bit of a briefing on what I was to talk about, and so I decided to lump it into this title here. So it's a fairly controversial title. What we actually know versus what we think we might know about the long-term effects of concussion, and putting science ahead of the hype. So I'm sure lots of you have heard a lot about what has been happening, particularly in the US, in terms of the research that's coming out with players that have passed away. Their brains have been donated to science. They've conducted autopsies and found a lot of tau pathology on the brains. They call it chronic traumatic encephalopathy and say that it's a result of all the head trauma that they suffered during their careers. I'm going to talk to you a little bit about that and I guess give my perspective, but also to bring the science into light as opposed to the message that the media gives and some of the researchers around the world have been giving as well. After I talk about that, I want to just discuss a few things that we're doing in Newcastle. I'm from the University of Newcastle, so some of the stuff that we've been doing in terms of research, and if anybody is interested in doing a research project with us, then I'd be happy to chat to you about that as well. So just disclosures in terms of funding and other disclosures. So I've received funding from the New South Wales Sporting Injuries Committee. I've also received funding from the Brain Foundation Australia with the Head Injury Project grant. I get free use of the Colk Sport Axon Sport program. I've been given money for travel and expenses for conferences and meetings to give talks like this. And also, as you already know, I have my own consultancy business, NeuroGuard, and I see current and former athletes, professionals, non-professionals in that capacity. So what I'm going to talk about is CTE, chronic traumatic encephalopathy. Now, in 1906, it was the first time in the Journal of the American Medical Association where things were mentioned in terms of potential long-term consequences of concussions. And so if we read the quote there, it says, at the present time, no one is ready to say whether concussion of the brain may or may not have serious consequences in afterlife. And what I mean by afterlife there is retirement. So 1906, first time it's been mentioned. Then in 1926, there was this paper that was published, and it says that the anatomic and clinical investigations seem to show definitively, that our conception of concussion of the brain must be modified. It is no longer possible to say that concussion is essentially transient or essentially a transient state, which does not compromise any evidence of structural cerebral injury. Not only is there actual cerebral injury in cases of concussion, but in a few instances, complete resolution does not occur. And there is a strong likelihood that secondary degenerative changes develop. So that's 1926. And in 1928, a pathologist by the name of Harrison Martland from New Jersey described punch-drunk syndrome. So he was referred 23 cases from a single boxing promoter, and he examined 5 of them personally and described one of them in his manuscript. And so he's used terminology like cuckoo, goofy, and slug nutty to describe the presentation of these guys. And he described also motor and cognitive symptoms. So it wasn't then until 1969 where anything really prominent came from the literature, and that was Dr. Roberts, who randomly selected 224 boxers from the British Boxing Registry, out of which consisted of 16,781. So a small sample, but nonetheless a very good study. And so in 1969, this is just a book review from not sure who reviewed the book, sorry. But what I wanted to point out was that Dr. Roberts is clearly not set out to prove a point, but simply to observe and record. So I want you to keep that in mind, because I think that's where some of the research these days has gone off track a little bit in terms of trying to prove something, and also having biases in wanting to find something in the methodology that you're using to conduct some of the research that's going on at the moment. So then 1973, we had Dr. Corsellis conducted neuropathology of 15 ex-boxers, and he described some of the neuropathology that he found that included atrophy, scarring, substantia nigra degeneration, neurofibrillary tangles found across all areas of the brain. So to lump together Roberts and Corsellis' clinical CTE findings, there's a constellation of clinical symptoms affecting a number of areas. Approximately 70% demonstrated dysarthria and Parkinsonism and pyramidal signs, but there was no progression, and they did not have features of dementia. But in 30%, they did demonstrate dysarthria. They also had cerebellar and pyramidal signs, and they also demonstrated progression and clinical dementia. So we're looking at a 70-30 split there. Now, in 1984, boxing basically reformed itself, or introduced some reforms as a result of brain injury. And so this paper that came out in JAMA by Ira Kassan, brain damage in modern boxers. So there was 18 former and active boxers. They had definitive evidence of brain damage, and they said that it's a frequent result of a career in professional boxing. So as a result of all of the evidence that have been conducted to date, plus that paper, that's where some of the boxing world governing bodies started to make changes in terms of management of head injury. What I will do is to go back to the Roberts case series from Britain, and you would have seen, and I didn't mention it, that it was from the registry was from like 1954 to something or other else, mid-90s. All of those boxers, or a large majority of those boxers, had fought in the late 1800s and early 1900s, where bare fist fighting was the norm. So there was no gloves, and also that these guys had careers where they were exposed to 500 bouts in a career, and that would be the normal. Whereas today, we've got boxers that don't even fight 50 bouts in their professional career. So it's a different kind of exposure for the boxers back in those days and what has been reported in the literature in those studies compared to what people are reporting these days in terms of the sport of boxing. Now, in 2005, it was the first piece of evidence or the first paper that had been published in what I've termed and other people have termed modern CTE. So it was the first time it's been described in athletes other than boxers. So Bennett Oliver, who's a neuropathologist, he was from the University of West Virginia, but he's worked on since then, wrote a manuscript or published a paper of a single case study of a former National Football League player, so American football player. And so that was the first time it had been CTE or a degenerative brain disorder had been mentioned in an athlete outside of boxers. Then in 2009, Ian McKee and the Boston group, so Ian McKee, Bob Cantu, Bob Stern, Chris Nowinski to a similar extent, are part of that Boston group, Boston University. They published a paper that included 3 case studies. And so in their paper, or the review article, they said at least 17% of individuals go on to develop CTE. And that was their reference to Roberts' 1990 paper in boxers. And they also said that it is progressive neurodegeneration clinically associated with memory disturbance, behavioural and personality changes, Parkinsonism, speech and gait abnormalities. And there is overwhelming evidence that the condition is a result of repeated sublethal brain trauma that often occurs well before the development of clinical manifestations. So then in 2011, Bennett Oliver and his team published another paper of 14 case studies, of which 10 demonstrated neuropathology consistent with their diagnosis of CTE. 7 out of 8 footballers, 2 out of 4 wrestlers, a boxer, and 1 out of 3 high school players. Then in 2011, another paper from the Boston group described that there's an estimated 3.7% lifetime prevalence in NFL players of CTE or a neurodegenerative brain condition. Then the really big paper came out in 2013 in Brain, which is a very, reasonably prestigious high impact factor medical journal, titled The Spectrum of Disorder in Chronic Traumatic Encephalopathy. And this was a case study that included 68 cases, 68 cases of positively, CTE positive cases of 85 brains. So a large percentage of them demonstrated their diagnosis for CTE. There was 50 footballers in the group, 34 of them were professional, 1 semi-professional, 9 collegiate and 6 high school players, 5 hockey players, 8 boxers, and then 4 individuals that had no history of contact sport. 3 of them were veterans and had been exposed allegedly to a blast injury, and then there was 1 individual who had autism and was a headbanger, self-injurious headbanger. Then there's another group that started collecting neuropathology cases as well. They're from Toronto. And in 2004, they published a paper with 6 cases, 3 of which demonstrated CTE, 3 of which did not. I think 2 out of 3 also demonstrated other neurodegenerative diseases as well. So there was only really 1 case that was pure CTE. They just had a newspaper article published yesterday of a 35-year-old former NHL, so National Hockey League ice hockey player, who demonstrated CTE. So that's a fairly young person at 35 years of age, had about an 8 to 10 year history of National Hockey League play. So we've basically got, in essence, 3 groups that are looking at this. There's a group in Toronto who now have 14 brains that have only reported on their first 6. We've got the Boston University group who have reported on 85 brains and have a lot more. And then you've got Bennett Oliver's group who have reported on 14 brains, but according to newspaper articles, they have a considerable amount more than that as well. So it'll be interesting to see when the next range of papers comes out. So Graham Iveson, Paul McCrory, and myself conducted a systematic review of the literature in 2013. It was published in the British Journal of Sports Medicine. And what we suggested is that there's a classic and modern definition of CTE. In terms of the classic version, we're talking about boxes. They were described by Corsellis, which I went through just a little earlier, and Roberts and other cases, basically pre-2005 when Ben Anomaly first came out with the case that was a professional athlete. And then we have the modern definition, which is almost exclusively based on the presence of abnormal tau and not necessarily clinical syndrome. So this is a table that I've just pulled out of the paper, and as you can see, out of all of the cases, there's 23.5% that have no neuropathology at all. And then of the cases that are pure CTE neuropathology, there's 20%, so 1 in 5 out of all the cases that have been reported to date. So there's only 20% that are pure CTE. CTE and other neuropathology, more than half. And then neuropathology, but no CTE is just under 5%. So there's a range of pathology that occurs, and I'll go into detail with that in the next few slides. But what I want you to be cognizant of or thinking about is that tau pathology, which is the hallmark of CTE, is itself a tauopathy. Some of you may know or may not know that Alzheimer's disease is also a tauopathy. The description of CTE is the presence of tau in unique locations. So the neuropathologists claim that AD is not really a differential diagnosis in terms of where they see or observe the tau being distributed in the brains of these deceased athletes. You may or may not be aware that tau also develops with normal aging. So most of you probably in your 20s you start to develop tau in late 20s. You certainly will have some in your 30s, and you have more and more as you get older. And that can be subclinical. You could have a lot of tau and have no clinical manifestation of anything. And so that's another concern that we have, is that these guys are collecting these brains and then retrospectively talking to family members and asking them about clinical signs and symptoms, and then validating the tau that's observed against those clinical symptoms and saying that the tau has caused this. I'll go into some detail about some of the major concerns that I have about that, particularly around suicide. So you may know that a lot of these, a few of these guys have passed away by suicide, and a few of them have left notes to say donate my brain to science. So it's concerning, and I'll go into that in further detail soon. So you can see, I've just introduced a little bit of the topic there, that the science has not really advanced that far, but according to the media, we know a lot about it, and that it's a huge problem, and that every athlete that sustains multiple concussions is going to go on to get a neurodegenerative disease. And so it's hit the front page of Sports Illustrated, it's the front page of Time magazine. It's also been in multiple newspaper articles. These are just 0.01% of what comes out. And so you can see CTE, 6th player's brain is found to have degenerative disease. That's a long time ago, 2009. There's lots more than that now. And then we have all these other headlines and articles. And then our own Ollie, you may or may not remember that he had a fall off a ladder onto concrete and was in the coma for, I think it was a couple of weeks, a few years ago. And so he was talking about chatting with the AFL and the NRL about brain injuries and brain damage. So what I want to do now over the next few slides is just talk about 10 important things that clinicians should know about CTE. And the following content is really going to focus more on what we don't know more than what we do know. So number one, it's poorly understood and no diagnostic criteria. So CTE has been poorly understood for more than 80 years. Prior to 2015, there was no widely accepted or empirically validated diagnostic criteria for either neuropathology or clinical features. So number two, from 1929 to 2012, there was only one large study. So the Roberts paper that we discussed earlier from 1969 was described in his book on a cohort of boxers, and that was only 224, and approximately 37 or 17% demonstrated neurological lesions, and he only really described 11 cases in his book. So 11% of them were deemed to have mild CTE, 6% were considered to have a moderate to severe form of the syndrome, and Roberts described what appeared to be two syndromes. One appeared to be static and the other more progressive. Now, in terms of number 3, the gross and microscopic neuropathology described in the early 1970s. So Corsellis described what he believed to be unique dementia pugilistica, or punch-drunk syndrome as it's referred to as well, in 15 boxes. And so that was neurofibrillary tangles and degeneration, neuronal loss, scarring of the cerebellar tonsils, and the cavern septum pellucidum, and fenestrations. Number 4, comorbidity with other diseases. So as I just discussed before, Alzheimer's disease, Parkinson's disease, frontotemporal dementia are all differential diagnosis in terms of clinical syndrome and also neuropathology. And we don't really know too much about that. And we also don't know, or we don't have a good grasp on all of these different things and how they appear in terms of neuropathology. So how much learning disability affects not only the clinical presentation or whether there's any greater susceptibility to neuropathology as a result of having a learning disorder plus many concussions you may sustain during your career. Then you've got ADHD, depression, post-traumatic stress disorder, so particularly when we're talking about the military population, other psychiatric disorders, alcohol dependence, drug abuse, and all of these other ones as well. So chronic pain is a big one. As you gradually get exposed to more athletes, you'll know that even current players suffer from chronic pain, and retired players certainly do as well. And so all these other things as well, so hypertension, any kind of heart surgery, cerebrovascular disease, and all the differential diagnosis of other dementias. So attention and working memory decreases across the lifespan in healthy adults. So to pin a diagnosis, a clinical diagnosis in life on some kind of attention or working memory deficit is potentially flawed and needs to be considered in terms of base rates. So we'll talk about base rates again in terms of suicide, which is coming up in 0.6 or 7. So 0.5, it's considered to be a neurological condition affecting boxes. So CTE was thought to be found almost entirely in boxes prior to 2005. And then there was an isolated case report of dementia pugilistica in people who were not boxers, including a Atlantic wife in 1990. And then Ben and and colleagues reported the first case in 2005, as we discussed a little bit earlier. There's been fairly dramatic evolution of both the neuropathology and the clinical findings of CTE in the past few years, especially as described in the NFL or American football players. In the past, CTE was diagnosed in some retired boxers who presented with serious problems, such as neuropsychiatric symptoms or Parkinsonism, whereas at present it's been diagnosed in young athletes with no or mild symptoms. Okay, so symptoms and problems attributed to CTE have evolved over the past few years. There's broad and diverse symptoms and problems have now been attributed to CTE, including headaches, anxiety, depression, suicide, and dementia. Now, you can appreciate that headaches is extremely insensitive to any kind of differential diagnosis that you want to make. People in the normal population can get headaches on a regular basis and they have no neuropathology potentially and no clinical syndrome to account for those headaches. So to use headache as a sign of CTE is ridiculous. So these symptoms have been attributed to CTE. And they're similar to depression. They're also similar to behavioural dementia. So they're two potential differential diagnoses that don't appear to be considered all that highly in some of the papers. So in 2010, Oliver and colleagues introduced in the literature that suicidality was a problem or a prominent clinical feature of CTE. Never been mentioned before until he mentioned it in 2010. And it appears to be based on the fact that 2 or 3 cases of that reported have completed suicide. And so have been introduced in the media over hundreds of times prior to the publication of that particular article. Now, we'll talk a little bit about suicide. So suicide wasn't a feature in the Roberts book, and it wasn't a feature in McPee's reports prior to 2009, but it has become very prominent in the book post-2009 as well. So in the published literature, all the known cases for 2009 didn't consider suicidality to be associated with or a clinically relevant feature of CTE. And it was not concluded in any of their extensive tables or in any of their papers that it was a possible clinical feature. It wasn't even discussed in any of the articles. In contrast, suicide is now widely cited in the literature as a clinical feature of CTE. So consider that's developed just a couple of pieces. And so let's talk about suicide a little bit. So it wasn't considered a clinical feature, as I said, for the first 80 years of writing in CTE. There was no confirmed cases of suicide from Roberts in the random sample of retired boxers. And there was only one person that was had a suspicious death. At present, there are no published cross-sectional epidemiological or prospective studies showing the relationship between contact sport, CTE, and risk of suicide. So there's been 2 review papers by Hal Waters and also by Green Anderson looking at those, and they both basically concluded that there's no association between CTE and suicide. So in a large-scale retrospective epidemiological study of retired NFL players that examined the death rates associated with cardiovascular disease, former NFL players were less likely to die of suicide than members of the general population. And according to the only published epidemiological study to date, NFL players are at a decreased risk, not an increased risk, for completed suicide in relation to the general population. So there's a mature body of research or evidence suggesting that the causes of suicide are complex, multifactorial, and difficult to predict in individual cases. In general, the rates of suicide in civilians and military has increased in recent years, and suicide is also a problem that affects athletes, non-athletes, or in non-contact sports, like baseball, and concern has been expressed about the rate of suicide in people from specific occupations such as physicians. So it's not just head trauma that leads to suicide. Now, number 8, so there's 4 neuropathological study of stages that have been introduced since 2003 by who, for the first time they reported that CTE could be diagnosed in someone who has no clinical symptoms of this change. So stage 1 can be diagnosed based on having small focal epicenters of the tau, or PTAM, phosphorylated tau, and no clinical symptoms, or symptoms such as headache or anger or mild depression. This represented a fundamental change in that now that a person is said to have a neurodegenerative disease in the absence of serious physical, cognitive, behavioural, or psychological problems. So number 9, so the Boston group created a new diagnostic criteria called genetic encephalopathy syndrome. And so it's extraordinarily broad, encompassing people with depression and with control problems, and those with genetic stage dementia. And so just for example, if you're a person at high school or collegiate sports for those 2 years and you have depression, anxiety, headaches, you have depression, suicidality or suicidal ideation and anxiety, if you have depression, suicidality or headaches, anger control problems, anxiety or headaches, any of those combinations, then you meet criteria for this diagnosis of this so-called disease or syndrome. So very broad. So many men identified as having CTE had depression and chronic depression prior to the death. Depression is not considered a typical clinical feature of CTE in the past 50 years until recently. And so CTE researchers have written repeatedly that depression is a clinical feature of CTE, implying that it was caused by tau pathology and other aspects of neuropathology attributed to CTE. So, as we said, causes of depression in men are diverse. Depression is not uncommon across the lifespan, particularly for men's lifespan. What is tau? So it's a protein, and when it develops in the brain abnormally, it leads to basically the product of the brain can lead to some cell death, and it can be detected now that there is a tau loading via functional MRI. So previously, for the last few years, 2 years ago, we weren't able to see it in the living brain. We could only use the same to see tau in the brain, but now the tau ligands are able to actually see it. So that's a big improvement in terms of technology and opportunities to see things, but not necessarily. Good question. I might just skip through that because there's a bit more I want to get through. So as you can appreciate, what I'm trying to say is that depression is A feature that can be caused by multiple different things that happens frequently in the normal population in people who don't actually have any exposure to UNSW or concussion. Yet it's now become a huge feature of CT over the last few years. Okay, so in conclusion, in terms of those 9, I said I was going to do 10, so 8. The neuropathology of CTE has been assumed to be the predominant underlying cause of a diverse range of clinical symptoms. But there are plenty of alternative hypotheses to consider, so that's point 10. What are the alternative hypotheses? Well, there's potential cognitive reserve, clinically silent neuropathology. Tau contributes in a small way rather than such a large way that they're reported in the literature. So CTE has evolved from a neurological disorder with features of, such as dysarthria and panic disorder and Parkinsonism to a broad range of subtle symptoms all the way up into dementia. The clinical features, as described in the past few years, are so broad and inclusive that a man with no history of neurotrauma or participation in context or who suffers from depression could potentially fulfill the clinical criteria. And therefore, when we consider the flow of former athletes, civilians, veterans who present for clinical services with depression or evidence of dementia, it is important to be cautious and circumspect in discussing the possibility that they may have this disease. So prior to 2015, no nationally or internationally agreed upon neuropathological and clinical diagnostic criteria for CTE, and this is now underway. And when I say nationally, more the United States, they're leading the way in terms of the funding that they have available to them and people that participate in this research. And so many of the autopsy cases have shown macroscopic and microscopic pathology consistent with preclinical Alzheimer's disease, frontotemporal dementia, Lewy body disease, cerebrovascular disease, and other neurological conditions. And some of these cases have met full neuropathological criteria for one or more of those diseases, not just CTEs. So researchers needed to better understand if at some point in the natural history there is a unique or reliable relationship between tau pathology and specific symptoms, especially depression and suicidality. So what we really need is a prospective study as opposed to the retrospective nature of the studies that have been conducted so far, which means that researchers need to probably forget about their goals and aspirations in terms of their career and start conducting really good studies now that they're going to pass on to the students, because they're not going to find the answers in their lifetime. It's going to be the junior players that are playing now that you get into a study and follow them up during their lifetime to find an answer to this, so that we're conducting longitudinal clinical pathological studies that are prospective as opposed to retrospective. We're getting interviews which are full of danger and inherently unreliable in terms of people's recall of clinical symptoms. So that kind of wraps up what I wanted to do to talk to you about CTE. If anybody has any questions, fire away right now. Yep.
Is there anything that's compared the presence of tau or any other disease in athletes to a normal population? Or
So all of the 3 groups that are reporting in neuropathology have not reported on controls in any of their studies. So it's a good point, and that's absolutely one of the flaws of the study, that a lot of them will mention when you talk to them and challenge them, but they won't say it in their papers and they haven't said it to the media. So they're kind of fueling the bias, extremely biased samples. The other thing is they're not just getting people who are available, who are former athletes and having a look at them. They're getting people who say, families who say, oh, yeah, they have heaps of problems. Here's their brain, have a look at it, oh, yeah, you've got CTE. So they've got an extremely biased sample. Yep.
Did you or any of the other studies look at any other research behaviours that are more prominent in the sporting or former sporting populations? Alcohol abuse, physical health, sport.
Yeah, so that's a good point, and a lot of the studies that have been conducted in neuropathology studies that have been conducted have got information on that, but again, it's retrospective and you don't know what the true rate is. I guess even when you conduct prospective studies, when you're asking somebody about their alcohol use, they can tell tips, but you still ask them. So I will go into our protocol that we've been using for alcohol, drug use, or recreational drug use, plus chronic pain I don't know of any neuropathology studies that have just looked at people that have never had an injury before and have abused alcohol, have abused drugs, have had chronic pain. These are the kind of studies that really need to be conducted and reported on to shed more light on the neuropathology of neurotrauma.
Yep, so we've got one last question.
Yeah, so thank you so much for the talk. I'm sure there's a lot of interest in this area with a lot of parents having kids who play rugby, especially in countries like Australia and America. So as you said, are there any prospective sort of databases being put together now from groups?
I'm sure there's plenty in the US that I know about. In terms of here, where I'll go into this in a second, but we're conducting a lot of prospective studies. We ideally would like to get a lot more junior players through, but at the moment it's very limited with funding. We've got a huge part of our research is neuroimaging, and as you can appreciate, that's extremely expensive. And so we need to get lots more funding to be able to do that. But good question. I'm running out of time, aren't I? Okay, right. Well, I'll just quickly go through what we're doing in Newcastle. So this is the team. So we're exploring reliable and valid ways to understand how the brain functions, conducting research in current and former athletes with a variety of history of concussion exposure. And we've published a number of recent papers. I won't go into them. If you want to ask me about them afterwards, we can. I'll just quickly flick through. So this is a paper that I published on clinical issues and decision making in terms of retiring as a professional athlete. And we discussed a few things here, but I just have to retire another case study of that. We've conducted a few systematic reviews in diffusion sensory imaging and negative protein spectroscopy. If you're not sure what they are, you can ask me about it. So the systematic review, I believe that was shown earlier. Going into it, we've also done a systematic analysis of concussion drug union, and there's really limited studies in both of those sports. One of the papers that we're just about to submit for publication is looking at spectroscopy in retired athletes. For those who don't know, that's basically looking at neurometabolites in the brain. So you place a voxel in the brain and you have a look at what metabolites are like in that area. So we had 13 athletes and 13 healthy match controls, and I'll just cut to the chase. So basically we found reduced NAA in the posterior singular gyrus, but it wasn't a significant reduction in NAA or increase in NAA in white matter. We put in the fly for white matter. Cohen's D, which is effect size, 0.65 is moderate effect size. We saw reduced myoinositol also in the PCG, and Cohen's D effect size of 0.9 is pretty strong. And then also reduced glutathione in the same area, and effect size of 1.43, which is astronomical. We've also conducted video analysis of concussions in the National Rugby League. So in 2013, I had 3 clubs provide information about their medically diagnosed concussions. So there was an N of 20. I went and reviewed the tape and wrote a paper about that. In 2014, those who follow rugby league will know that there was an introduction of the concussion interchange rule. We had a look at all 16 clubs. The rule was used 167 times in the 2014 season. 5 of the videos weren't very good, so we couldn't use them. So we had an N of 162 that we went through and had a look at. So from the 2013 data, there was an incidence rate of 14.8 per 1,000 player exposure hours, or 1 concussion every 4 games for those 3 clubs. 83% of the time, the person making the tackle was going high, so in the torso or above. Loss of consciousness was observed in 30% of cases, and illegal play accounted for 25% of those concussions. In 2014, because the definition of using the rule is a bit more lenient than medical diagnosis of concussion, the incidence rate was a little bit higher, so 24.03 for 1 every 2.4 in all games. The ball carrier was the injured person in 43.2%, the tackle at 54%, or 55% across it. And 1.9%, neither of them were in possession of the ball, so they were competing for a cross-field bomb or there's a couple of cross-field bombs. On one occasion, it was a player that took out front of the so the hit-up, where a player runs solidly trying to make ground, into the defensive line, accounting for 62.3% of cases. Most of the cases were seen rapidly on the field, and the large majority of them were taken off straight away. And this is just a table. This is my last slide. So this is just a table of some of the findings that we found. If you want to get out of anything interesting, so the total samples here. This is of the players who did not return to play, so there's 76, and of the players who were taken off but returned to play, there's 80. So there's symptoms there. So it's a little bit concerning that 23.8% of those 80, so 19 players had observed loss of consciousness, yet will return to play the same game. So that shouldn't really happen. And so this paper is under review in the American Journal of Sports Medicine. And so ongoing research questions, we're looking at retired athletes, we're looking at acute biomarkers and current athletes. Thank you.
Very much. Yes, question. Yeah, one quick question.
Yeah, you with the last table you put up, what that it was yes, no, and missing, both missing.
So so in the missing table, that means that although we had the video, we did have sufficient video to see if they had suffered a loss of consciousness, loss of muscle tone, etc. So those were the ones that we had the video, but we didn't know we could code it basically. So that's just missing down.
All right. Well, on behalf of UNSW Medicine and UNSW Sports Medicine, I'd like to thank you very much for giving us a great talk. All right. Next up, we have our lovely sponsor, Edway, who would like to say a few words and hand out a few flyers. So, without further ado, let's bring them up. Yeah.
Coming here. Oh, how is everyone? All good. I actually I went to this uni. I started in 2000. Right. I picked the easy degree, and unlike you guys. Actually, I thought I was coming here and I'll be talking to a bunch of physiotherapists, but I was wrong, right? So, because my usual area of expertise is business and the motivation. But I'm sure whoever's in this room is already motivated not to be here on 7 p.m. on a Wednesday, right? So, and I thought, well, what the hell am I going to talk about, right? And I thought of one story that I think I know about sports medicine, right? And then at least it's fun. Oh, well, you'll be the judge of that, but we'll see. Okay. When I was a kid, I used to do some sport, right? I used to do swimming, I used to do judo, and I just used to fight on the street, right? That was back when I was in Russia, right? But then I realized fighting felt great, but no matter what you do, you're not going to be good at the bullet. And that's why my sport of choice at the moment is actually shooting. Right? So it's still a sport, right? So you go play target, you just go on the range and shoot, etc. In Australia, it was great. You can actually pay the farmer like some $100, so it's about $300 or something, and go and shoot in his farm, right? And you go and shoot. Well, I mean, the idea is you go hunting, right? That's what you call it. So you go and shoot, try to shoot animals, right? But you can imagine, like, you get 10 guys, like, getting away from their wives or girlfriends or whatever, right? And you got, like, over $1,000 worth of bullets, right? What do? You start shooting left and center, right? And coming back to sports medicine, on my second last trip, right? And we like shooting. Who knows calibers of weapons here? No one. Okay. Can you imagine what a 2 to 3 bullet is like? 2 to 3, right? It's about this big, yeah? So the muzzle velocity close to about 1,000 meters or so, yeah? 1,000 meters per second. So it's not nice. I mean, the range is about, you'd be lethal about, maybe 800 meters. Like if you elevate. So besides the point, So the way it usually happens, we get on a ute, right, and start shooting anything that moves. Obviously, no animal gets in the way, because if it's an animal, I mean, we don't want to kill animals, right? But if it's an animal that gets in the way, it's probably an animal that deserves to die, because he was deaf to let us get to that place anyway. You know what I mean? It's natural selection, right? That's all great. So besides when we go on the ute, there's obviously beer and everything, right? And then we see a rail, right? So just a rail, and like the train goes there, right? So the train will go, right? And one of the guys goes, "Oh, I'm going to shoot the rail." I go, "Oh shit, we probably shouldn't," right? And before I said it, he goes, "Hey, we're talking maybe 3 meters down on the incline of maybe 60 degrees or so," and I'm standing behind the guy. And next thing I know, I got a bullet in my face, right? Ricochet. We're talking, it came down 180 plus up, right? I got a bullet in my face right here. The bullet is disgusting, right? If you follow me on Instagram, well, that's next. So right. So then I thought, Jesus, now would be a really good time to know about sports medicine, right? And I thought, right, Jesus, here we go. And the funny thing is, and like I thought nothing happened. Actually, I saw the 3 pieces, right? The 2 to 3 would be about close to about 9 or 10 grams, right? And I put it separate in about maybe 3, 4, 5 pieces. And the 3 of them went to my face, 2 of them bounced off the glasses, and all one of them trained thin glasses. Well, they were trained 10 years ago, but this had one of them thin glasses, and actually scratched the glasses. And I thought, shit, I'm lucky. And that's where my other education comes in, right? I've done actuarial studies, right? So it's a game of chance in a sense, right? But besides the point, coming back to the original story. And then I thought, actually, sports medicine would be cool. And I thought, but there wasn't really much to do there, though, right? So, I mean, I'm here, and the first thing I do was take a snapshot of Instagram, right? And I go, and then, like, I put blood coming on my face and everything. That's a cool picture to pick up cheap. You gotta look at me, I'm gonna. Nah. And but there was no reception, so I couldn't upload, right? And the funny thing is, and then I thought, yeah, it's all good, and then it all healed by itself. And one day I'm just looking and touching it like this, right? And then I feel something just dropping, go bang. I go, oh, this is funny. And the piece, I didn't know there was a piece in it, right? I thought I expected there was a piece, but luckily I didn't know there was a piece. And the piece dropped down in the eye socket. And I go, oh shit, this is sad. And then I think, all right. And then I go to GP, right? And he goes, what's wrong? I go, oh, well, I got something in my face. He goes, yeah, how do you get it there? And then I go, well, if I tell the guy that it's a piece of a bullet, he's probably going to refer me to the cops. And I go, unfortunate story of how the hell did I end up with a piece of bullet in my face, right? So, but the guy, like, and I go, you know what? I was stuffing around with the angle grinder, and I got a piece in my face. He goes, oh, yeah, okay, let's remove it. That's we're talking in just medical center. There's no hospital, right? So the guy goes, all right, well, let's not do it local anesthetic. I go, okay, all right, let's not, because he looks at it and he goes, oh, I can't really feel it. Well, what? This was a big piece. And he goes, oh, pain. I go, oh. I go, no, man, it's not out, right? He goes, oh, shit, maybe we should do it. I go, yeah, maybe we should. So he's teaching me the local anesthetic, right? And it's all fun and games and everything. But then he goes, he does it, like, he tries to get it out for about maybe half an hour. And I can see the guy's giving up, right? And he's really sweating and getting to the bottom of things. I go, Mike, all right, let's just get the thing out. He goes, maybe you should do slow language. I go, Mike, no. And then he goes, then he gets it started, cuts it again, and then he finally gets it out, right? But we're talking, because it was so deep, right? That anesthetic was only on the surface, you see. So it was one of the most painful freaking moments of my life. Meanwhile, I'm on Instagram. That's why, if you want to see the picture of me with a bullet taken out of my face, it's my Instagram. I'll let you know later. But besides the point. So the guy goes, okay, let's. This is good. Well, we should probably send him to pathology. I go, how's it going for time? Good. Right?
Yeah, we're good.
All right. We should probably send him to pathology. I go, Mike, yeah, let me just look at it. And it's wrapped in tissue. I go, no, man, let's not send him to pathology. So I kind of bring the tissue and give him the tissue, and I go, yeah, okay, I'll take this. He goes, oh, but let me look. He goes, oh, that was a big piece. I go, yeah, shit, it was, wasn't it? and it was like 5 mil by about 3. All right. But besides the point, that's what I know about sports medicine. In terms of the company, right?
Great segue.
No, but when I said I usually do talks about motivation and business. I mean, just a few things about the company and everything, right? I became a millionaire before I was 25. I was most of it before I was 25 as well. I never worked in a profession in actuary, right? And last 2 years rather, I spent most of my days down in Roundhouse, the Silver Roundhouse, yeah? Yeah. Maybe I didn't know at the time, but I think I was researching the RSA, which you now do. No, I wasn't really. But besides the point, so we basically we're one of the biggest providers of mandatory courses in Australia, right? And those courses come in first aid and education, right? I know nothing about first aid, right? Actually I do. That's a story. So I'll be quick. Right? We're good.
No, not so much.
I'll be quick. Right? It's a good crowd. Right? No, the first aid, right? When resuscitation, right? When you resuscitate someone, right? They want actually getting someone back to life, right? 7%, right? Like before, like the first aid all these updates, right? It's 7%. Now 7% is pretty shitty odds. If someone tells you, you know, how the chance, like if you give me your money, the chances are that you 7% with the chance that you're gonna make something out of it. You know what? Yourself, right? But yeah, 7%. So that was with the breathing into the person, right? So I'm not sure how to go. Yeah. But basically, the funny thing is they increased the odds. They recently changed the protocol, and now it's continuous compression, right? So 100 beats per minute, yeah. And the odds actually increased to 8.25. It was pretty cool. So I mean that's why first aid is fun. That's fun. All right, thank you guys. And yeah, we'll do a special deal because we're supporting UNSW as is, but for this particular case, we'll do a special deal for it's $50 for anyone that wants to take it. Thanks for having us.
If you want to just take a flight.
No, we'll actually pass it. We'll need to give it everyone, right?
Yeah, that's nice.
Yeah, just get your flyer and yeah, thank you for listening. Let's see,
All right. So. Yes. Okay. So whilst those are going around, we might just announce the winners for 2 of the 5 first aid training courses. So these have been randomly chosen, and the first one is I can't even read this name. The first one, Tavish. Where's Tavish?
Hold on. Riveting tale.
The first person
Riveting tale.
is Michelle Lau. Here, come on down. We'll just take a photo for the winners. Okay. And the second one is. Alright. I'm gonna read out your student number because I cannot read your handwriting. So you are well on your way to becoming a doctor. So the student number is Z3462671. And you are an ARC member. Who is it? Put your hand up. There we go. How do I say your name? How do I say your name? Okay, hold it back. Congratulations. You got a free first aid course. Alright, so we will draw the other 3 at the end of this. So you guys are
You make some more.
I'm sorry, So, we're going to start with practical sessions now. There's 2 of them we're going to go through. There's concussion station, so how do you identify a concussion if you're on the sideline, if you're a sports dog, or if you're a medic on a field, which is, for example, what you could do if you had a first aid course and wanted to work with the Concussion rugby class or something like that. So we'll teach you that, and that'll be hardware, techniques to do that. We're also going to do some basic life support and CPR. So, just quickly, what we're going to do is just run through real quick the theory. Put your hand up here if you have. We're just going to raise your hand if you've done basic life support before. Okay, so that's good. So it's most people. So what we're going to try, we're going to run through this real quickly for those who haven't done it before, but we're mostly going to be practicing. Because we've got 4 dummies out there, 2 from Prince of Wales and 2 from Edway, and we're just going to really focus on frequently asked questions, things that are normally done wrong, and just getting you practicing. Because unfortunately, we get taught it in our course, and all of us will, BLS and ALS, but you hardly ever get a chance to practice. You don't want to be practicing the first time or the second time on someone who's nothing. So, basic life support. This is basically, well, that is exactly what it is. That's from the Australian New Zealand Resuscitation Council. It's literally danger, response, send for help. Your airway and breathing are pretty cursory in the newer protocols, and it's mostly CPR. The only numbers you have to remember for this are 30 compressions and after that 2 breaths. And we'll be doing those breaths with a bag and mask outside. The defibrillator is not required, although it does significantly increase the chance of survival.
Okay, so as we've just kind of alluded to, basic life support is just the temporary maintenance of breathing and circulation, and it's usually used as a bit of a temporary measure between when you can get people and equipment for advanced life support and more serious emergency equipment. And so when you're doing compressions, it can only achieve 20 to 30% of the cardiac output level that you had before a cardiac arrest. And also when the breathing is put into place, it's only 15 to 18% of the required level of oxygenation. So that's why it's only a temporary measure, and so you need to quickly escalate very quickly. And so defibrillation is used if you've got VF or pulseless VT. That's again part of ALS, and that comes in ones that you can shock, but in things like asystole, it won't work because you don't have the change. And so then the main purpose of that is to just maintain the cerebral and myocardial oxygenation until you can get to ALS. And so what the advanced life support is, it's pretty much the same thing initially, but then you've got additional invasive techniques that can be used. That is defibrillation, airway management can be a bit more sophisticated in terms of the equipment you can use, and it also can include IV access and drug therapy so that then you can get into the ED and get what you need to do.
So you kind of understand the difference between advanced and basic there. Yeah? Okay, so we're just going to move on. So what we're going to be practicing outside really is cardiopulmonary resuscitation, CPR, right? And so, as we said, consensus is, and studies have shown that 30 compressions followed by 2 breaths is the way to go. What our lovely sponsor was trying to, well, did mention, was that in a roundabout way, that actually it's more important to be compressing than to give the breaths, because a lot of people stop the compressions to give the breaths, or they give the breaths, or they're too worried about giving the breaths and they don't compress. And that's the difference between the 7.5 and the 8.2 when they change to completely compression only resuscitation. We're not teaching you that, and you can practice that if you'd like, but for trained medical personnel, you do want to be ventilating the patient as well. But these are often done in teams. The other thing is how often you do it, and we've got this lovely song for you. Oh, it's so soft. I'm supposed to be super loud. All right, don't worry. Okay, so we'll go back here. So that's the kind of timing you're supposed to do. And where the compressors are things. So just when you get out there, make sure it's in the center of the chest, and that means over the lower half of the sternum. And this is doesn't actually need to be too anatomical, but if you're way up, like on the top half of the sternum or the nubrium, it's less effective. And if it is in the abdominal cavity, then that's obviously okay. So the other things. So the major thing with CPI is a lot of time people don't do the compressions deep enough. That's the major thing. A lot of people go, oh look, the mannequin's like chest is moving. That's fine. Just give me a little massage. No, it needs to be at least 4 to 5 centimeters. And some courses actually teach like a third of the chest. So when you think about what you're doing, you're massaging the heart, right? You're literally squeezing the heart. So I don't know how great our anatomy is at UNSW, and that's a completely different point. But you need to break ribs when you do this. I mean, to get to the heart, there's some ribs in front. So when you actually do CPR, you're breaking ribs. So you need to practice as if you're breaking ribs as well, right? And research shows that compressions are mostly done incorrectly, right? So, and then the other thing is, because you have to be pressing so deep, these often become shallow, you get tired. And so this is why you need to be swapping, and the ARC says that you should swap between 1 and 2 minutes, which is actually pretty rapidly, particularly when you're in big teams. And so yeah, so that's all I really wanted to say real quick about that. And then Dr. Dave Sammer was supposed to be here, but he is running a little bit late, so that's okay because we're going to practice outside. So I'm not sure how we want to do this. Who's more interested in learning the concussion, and who's more interested in doing the BLS? So let's hands up for BLS. So it's mostly concussion. Oh, no, BLS? How many people BLS? Just put your hand up, like right up high. Okay, so we just want to know. Okay, so that's what, half? Maybe less than half. Tentative half. Okay, so everybody who wants to do that can follow me and we'll go outside. And everyone else, Carlos is going to take you through concussion.
Yeah, and you guys can swap over as well because they're both valuable. I mean, BLS is going to be lifelong valuable. SCAT is very much relevant to concussion in sports and sideline management. So they're both useful skills to have.
I'm going outside.
Yeah, I was wrong now.
Oh no!
So grab your attention. So today we just want to run a few practical sessions for you guys to practice what it's like doing the SCAT, which is the Sports Concussion Assessment Tool. And this is a standardized tool to try and assess someone on the pitch who has suffered from a concussion and try and assess whether they can return to play or not that very same day. And they essentially came up with this tool. It's endorsed by a lot of big organizations, FIFA, the Olympics, and whatnot. And it's pretty much the standard that they use to measure it. Some of these, it's split into, I think, 4 or 5 key sections. One of them is obviously symptomatic. And the ones you've got here on the front, you're probably a bit more familiar with, like the Glasgow scale, right? And then there's a few to do with balance and things like that. And we'll actually have a go at practicing some of the balance stuff, which can be quite difficult. The reason why we want to maybe get you guys practicing is because before any player commits to a season, they have to do a baseline. And you're going to see why when you do the balance. But the baseline is really important. So just to start off with, who can tell me what concussion is? Anyone have any ideas about what concussion is? Say if you have to write it on an exam, or you have to tell a patient. Say you have to tell a patient what concussion is. What would you say? Any takers? Or what do you think are some of the symptoms of concussion?
Like head trauma, sometimes consciousness.
Good. So sometimes it results in loss of consciousness, not always. So a lot of people, when you ask them, oh, what do you think it means to be concussed? A lot of them will say, oh, it's when you get knocked out. That's not necessarily true. And it is often through head trauma, but like Dr. Gardner showed, a lot of it can be forces transmitted through the trunk, and that ends up impacting your brain. So he was talking a lot about CTE, which you can find on neuroimaging and postmortem. But in terms of doing acute diagnostics, a lot of the definitions say that concussion, there's a lot that's not known about it, but it's a transient state where there's no acute structural damage at that point in time. So yeah, does anyone know any other symptoms that you might get? Yeah,
Disorientation.
Yep, disorientation. Dizziness is a good one. Memory loss is a big one, which SCAT also assesses. Muscle weakness, yep, good. Any others?
Nausea.
Nausea, yep, good. Headaches. Headaches, yeah, good. So let's have a look at, I think it's on the second page. Here. So this has some of the key symptoms and signs that they ask patients and athletes. So they ask about, like you said, headache, pressure on the head, neck pain, nausea, vomiting, dizziness, blurred vision, balance problems, which we're going to look into soon. And there's a whole list of them.
We also ask them to look up, because it's saying something like rugby, you're at a stadium, most likely at night, if it's a professional game. So if they look up at the rim with the lights and get really out of it, it's a pretty significant factor.
Yeah. And Kristen's probably had more experience with doing scats and concussion testing and things like that. So yeah, a lot of you mentioned being disoriented and having behavioral changes, which is a big one. You guys might be familiar with in the World Cup recently, the Football World Cup. There was a German player in the final who got concussed, and he looked extremely normal on the field. But a lot of his teammates was reported after the game that he said a lot of weird things to them. So the World Cup was in Brazil. He thought they were in Ruhr in Germany in the 1920s, and he asked his captain to let him be the captain for the rest of the game. And he went up to his goalkeeper and said, "Oh, can I go in goals for a while?" And at halftime, he had to actually ask the ref, "Am I playing in the World Cup final, or is this some random game?" And so it was at that point that someone knew that he was concussed, but also raises a lot of blurred lines between what medical staff will do under the duress of the managerial team, which is also another controversial area of concussion. But
where a lot of the different sports had to come down and be really strict on guidelines. And I know a lot about the rugby side of it, so I can just mention that briefly, but they've had to have a protocol going from the governing body to the individual teams and to the doctors and the referees, so that if anything happens and any one person within that group deems that there's been a problem, like if they see someone just lying down too long, they're off until they're assessed. If they wobble and aren't walking properly, if they're looking like they don't know where they are, anything like that, it's an immediate off the field, and they have what's called the head bin, like syndrome, where they do this SCAT test and compare it to the baseline scores so that they can look and see that there has been a problem. And if they fail that, then you're off for the whole game, and you've got then following week's protocols where you have to pass all those tests. But it seems like with what Dr. Gardner was saying, the rugby league and a lot of other sports, they're not quite as strict on the protocols yet, and so that's definitely an area that they need to follow up.
Yeah, I know in soccer and the EPL, it's been such a big issue that they now hire an independent doctor who's available in the tunnel, and they're specifically there for SCAT and for concussion. And that way they know independently and not under the duress of the manager's team that this player cannot return to play. So yeah, it's quite a controversial issue, and a contemporary one. So I think Dr. Samra and Dr. Orchard have a lot more experience with it, and they'd like to be able to talk about it. What I want to do now is just quickly go through one aspect of the SCAT test, which is a lot of these you can see online. If you just type in SCAT into Google, or SCAT3, which is the latest one, it will come up. It's the first link. It was published in the British Journal of Sports Medicine. The first one's the GCS, which you're familiar with, trying to assess it to what degree a patient might be in a coma or dead or alive and responsive. You've got the MADIC score, which is very much about orientation. Which venue are we at today? Which half is it now? It's sort of similar to some of the things you might see on the mini mental, right? Then you've got some background things, so history and symptom evaluation, which we briefly talked about. We've got the cognitive and physical evaluation, and the one I wanted to focus on today is balance, because this one's a little bit fun as well. So if you guys want, if you guys want, if you can stand up and find some space in the room, And you can come out to the front as well and pull your chairs. And just give yourself enough space to balance, right? So don't be doing your student balance exercises.
When did I get this?
Now, so the first one is yeah. So it's all yeah. So the first one is starting with both of your feet apart, around hip distance apart, and you close your eyes and you see how you count to 10 seconds. I think it's 30 seconds.
It's 30 seconds.
Yeah, but that takes too long. So try that, but let's do it for 10 seconds or 5 seconds. So everyone close your eyes and your feet hip width apart. And some people cheat. But you're pretty much fine, right? So you get a score and you mark it on the scat sheet, and this would be your baseline. So this might be in pre-season where your doctor, your team doctor is writing this out.
And they count the number of fails. So say more for the one, like one that you do this and you touch, but you keep going, you've got to keep going, then if you touch 4 times, and that's the score.
Yeah, so do you want to, let's have a go at some of the other ones. So the next one is, so you have to stand on your non-dominant foot. So if you're playing soccer and you kick with your right, your non-dominant is your left. So standing on your non-dominant foot, try and balance on it, right? And then close your eyes, and we count for 30 seconds. And I want you to count how many times you stumble and you put your upper leg down, right? So we've got one here. Come on, guys, be honest. See a lot of wobblers. Make sure your eyes are closed. We've got one there, Daniel. Right, so, all right, you guys can open your eyes now. Some of you found that difficult, right? But are any of you concussed? No, right? So this is why the baseline is so important, right? So some of you might have, you know, I don't know what the average number of fails are.
Depends for you. What would some of the reasons that you think for why someone would be really useless at this, but can have have never had a concussion? Ankle stability is major. And so a lot of the players have had recurrent ankle sprains, operations, ligaments that are just gone, and so then they touch some of them 4, 5, 6 times in 30 seconds, and they're elite athletes, and then you've got the ones that just don't move and do it perfectly. So it's usually ankles that are the main ones.
And the last one is tandem. It's just tandem stance with your non-dominant foot behind your other foot. So tandem is like this, right? So I'm right-footed, my non-dominant's my left, so my left behind my right. And you close your eyes, and again, it's a count to 30. This one's difficult as well, and essentially counting for how many times you wobble and fail. Does anyone have any issues with that one? It's a little tricky. Some of these are tricky, but that's why you can understand why baselines of scat is really important.
And gate one is what they do in the 5-minute headbit quick screening test. You've got 5 minutes to do all of this stuff.
Yeah.
And so there's a 3-minute tape, and they've got to do hill toe walking without falling off the tape, there and back in less than 14 seconds, and if they muck it up, they're out as well.
Yeah, and I think a lot of professionals, they do it in the boots or the shoes that they actually wear on game day rather than these. So understanding in cleats or studs and trying to do some of those. So yeah, it's pretty tricky. That was the main one I wanted to go through today because it's short how we go for time.
Yeah, who's there out there? So.
Yeah.
You
Yeah.
guys have any questions about concussion or actually stuff with that? I'm gonna ask her.
Now I need to find out.
Don't tell her that. I'm going to ask her.
Hey guys, just so what about how those things speakers? What you did? And we're just wondering whilst the BLS guys are finishing up, whether you can give us tips on doing a scat. Is that just let her do one? Or Putting you on the spot here.
Yeah, look, oh, no, if you haven't talked on it for, I'll add links to that reference. SCAT's something that is trying to make concussion assessment objective, but it gets there halfway, and the funny thing is that it's actually, in some ways you don't really need SCAT. If you're skeptical about the diagnosis of concussion, then you can make the diagnosis. It's a bit analogous to, as med students, you all learn how when you're studying medicine and learning how to be a doctor and see a patient, you meticulously have to go through your history and examination and or in a very sort of formula-like fashion to say, well, if I've got a patient presenting with chest pain, I've got to ask A, B, C, D questions, and then in real life, doctors in clinical practice, trash all of that and shorten and think much more in a get to the answer quickly rather than having to go through meticulously. So when you've got med students and interns, etc., doing histories on patients, it's like sit down and it'll take you 45 minutes to do a history because you've got to ask 57 questions and then consultant will come in and ask 3 questions to say the diagnosis is X. So it gets a little bit like that in that concussion. The more you have experience, the more you can just pick it instantly. So that's concussion, and we don't need to do another 48 questions. It's like what's based on. You can have a single examination finding or a single question you ask that will establish a diagnosis, and then the rest of it's all buffer and filler. But it's controversial in that at the moment you're all probably aware that concussion is a very rare area where if you're working in sports medicine, you're half doctor and half person. At the moment, there's all cardiology rules that the concussive player can't stay on the field, and this is where the push towards independent doctors in professional sport is coming from, because as a team doctor, your job traditionally has been to help your players get back on the field if they can, particularly to weigh up match factors with injury factors. So really important game, you're playing in the grand finals, the concuss is not that bad, or we'll let the players stay on. Now there's rules to say, well, concussed players aren't allowed to stay on, and so this is a very important part of that documentation. So actually at a professional level, a SCAT's something you've got to complete as a compliance thing as much as anything else, even though the diagnosis is a little bit fluffy. There's not actually a pass-fail number in SCAT. It's more a matter of you've got to use it as documentation to say, look, I let this player back on because here are all the things that players are able to do to prove that they weren't concussed. And if you've got someone who actually was knocked out unconscious, eyes closed for 15 seconds and then woke up, a SCAT doesn't matter in terms of you spend a significant amount of time unequivocally unconscious, you're concussed, and you can get away with a SCAT, but that doesn't take away from the diagnosis of concussion. So SCAT it's a useful tool to learn, but it's also useful to have the context in terms of what it doesn't do. It doesn't get you out of jail. Trying to send a player back on the field who was knocked out, they were knocked out, they've got concussion, they're going to be recovered on SCAT. And then if you have ruled out concussion based on a SCAT, then you've got to have a meticulous completion of it to actually prove to the chief medical officer what it believes you to say this player was allowed to go back on, and here's the documentation to say that every test possible was done and they passed it. So. Cool. How you doing?
Good, yeah. So
this is my colleague David Samra, who's on the sports med training program. So that's right. Well, it depends on whether we need to get progress.
No, we are going to. Just as an update, guys, before we answer them, this is an update. We're going to get a whole bunch of pizzas in as well, so if you're hungry, don't worry, we're covered. Yeah, so take that question.
said that, the other person said that you need to put exactly what baseline is scats.
Yeah, it's interesting. It's a good question. The question was, do you need a baseline to have a scat? And the answer is it's certainly improves the validity of scat if you've got a baseline pre-season. So it's recommended that you do. But you can do a scat, you can actually get value from a scat without a baseline. So it's not totally useless without a baseline. Whereas there's some computerized tests which are more designed for delay the turn of play. So scat is designed for game day assessment. You've got 10 minutes, can this player get back on the field because you've got a limited amount of time. Whereas a test like a COG score, which is a computerized test of reaction time on card games that they play to see if they can remember cards, react to cards in a quick amount of time. That one must have a baseline, or it won't give you an answer. Like a computer, that's assessing COG score results won't even give you an answer and won't give you a clearance unless you have a baseline compared to it. You understand the variation on reaction time is so individual that you can't compare your post-injury with a pre-injury status. Whereas a scat is a little bit more vague. It doesn't have a pass-fail number, and if there are some fail questions in there, if someone had a baseline to show that they were smart enough to be able to count catches pre-season, then you can say, well, they should have been able to do it after their injury and they couldn't, and therefore that's a deficit. But this is where scats without a baseline gets a little bit subjective, because you'll have a rugby league player and say, oh, I've got anyway, what else is this? Well, I've no idea. And it's like, not because I'm concussed, it's just because I'm done, and so when you've got baseline, you can get much more of an idea.
I do tank on the baseline.
American term that's sandbagging. They've had this sort of stuff, this concussion's been bigger in the NFL, had this for longer than in the US. So that's about the phenomenon of sandbagging, where a player will deliberately try to do poorly on a baseline test so that they're giving themselves more leeway to try and pass on that shot. Yep. Are we all in it?
Yes.
Okay.
Is this everyone?
Okay.
All right, so just to introduce, this is Dr. Professor John Orchard from the University of Sydney. John's a sports physician who's had over 20 years of experience in sport and exercise medicine, and sort of one of the founders of sports medicine in many ways in Sydney, and worked with the Roosters, was it 15 years or something?
Yeah, 16 years.
16 years, so, but out of that game now, so now mostly works with Cricket Australia as their Chief Medical Officer, and at the University of Sydney as well. So I'm John's registrar. My name's David, and I've been and I'm in my second year of training now. So I thought I'd just come and give you a little bit of a talk. John and I recently went to a conference in Doha in Qatar. That's a conference that's run by the IOC medical committee, and they basically hold an annual advanced trainee sports physician course. So sports doctors or orthopedic surgeons, rheumatologists, people with an interest in sports medicine from all around the world, working with their, they may be working with their Olympic teams, come over and it's like a 3-day pretty intensive course, and a bit of fun as well. And there was this is very topical concussion at the moment and head injury. So as John's saying, it's becoming more standardised, and the liability behind it is also an issue. So it has to be done properly, and the Chief Medical Officer for all different organisations, rugby league and union, AFL, they're all, and even cricket, all have their eye on the performance of doctors at the lower level, and we're trying to make invest rules in the game that protect people's the long term. So some things that were pointed out at the conference, I thought I must do about 30 to 40 scats a year with my work with rugby union at Sydney. So I do a lot of scats, and when I say 30 to 40, I probably treat maybe 20 concussed athletes a year, and you have to follow them up for 2 or 3 times. So it's
it's designed to test and retest. That's the whole point of the SCAT, and detect change over time. A couple of things I thought I'd share with you, just in terms of the actual SCAT and how it's done. Have you been through with Andrew Gardner the components of the SCAT? I imagine
we just did briefly.
Yeah. So did you guys try it yourself? Did you sit the SCAT, the symptom questionnaire? Okay, that was an interesting part of the conference, that we actually all filled out the symptom checklist, and virtually nobody was zero for everything. I had a pretty bad hangover, so I was right up there with headache. But yeah, no one scored zero on it. So that's something to bear in mind, and not just be ruling athletes out with concussion when they've got minor symptoms. These questions, somatic score, are more sensitive to athletes, obviously designed to test things that an athlete should know. But a perfect score does not exclude a concussion. And what I think is the most important question when you run over to an athlete you think is concussed is to ask them what happened. And if they can't tell you and make good eye contact with you, and they can't tell you exactly what happened, or they appear vague, you have to have a really high evidence of suspicion. Where it's a sport where there's a headwind, you just pull them off straight away. Where there's a sport where there is no headwind, which is the sport that I work in, you've got to run up and down the field with them whilst assessing them, which is actually really difficult and not optimal at all. So your judgment comes in, is the main factor here, even though you've got a standardised test. So if you actually look through this, and you're meant to get the athlete to fill it out themselves, you're not meant to ask them each question. Studies have shown that athletes answer this more honestly and will report more symptoms when they do it themselves. So give them the pen, give them the piece of paper, let them go through it. Whether it's because they think you'll think they're dishonest, so they feel like they're meant to admit to more symptoms, I'm not sure what it is, but certainly you get an idea of the number of symptoms and the severity. And it might just be that they've got a heap of minor features that raises a suspicion. But again, there's no cutoff, there's no magic number that you say, okay, we're concussed. And it really helps just in general whether if you know the athlete. No, there really isn't anything. Because you can see here there's one that just says, don't feel right. And I actually, that's the weirdest thing. I actually think that's the most heavily weighted need. Like if they just say, I just don't feel right, and they can't explain it, then that to me is, well, something's not right in your head, it's not functioning well. And at a younger level, like I work with under 20-year-olds, if they don't feel right, then why risk it, like a young brain, whereas I think if you have really minor symptoms and you knew the athlete and you worked in the club for 15 years, your judgment is going to be better than somebody else's if they just had their first day of the job. So, but yes, this is an important part down here that asks you to try and obtain how different their personality is from usual, which I think most of the time you give you a good indication of who's done this. If you've got the opportunity, the same clinician should see them again, follow up them to try and detect differences as well. And looking at this, just wanted to point out with immediate memory, you're meant to ask the athlete to say back to you the 5 words in the order that you've said them to them. And you have to do it 3 times in a row. So does she say elbow, apple, carpet, saddle, bubble, and you're meant to leave about a second between each word, so that the faster you say all 5 words, the easier it is to recall it. So you actually have to sit there and say elbow, apple, carpet, saddle, bubble. It's tedious. You have to do it 3 times and give them a score out of 15. So sometimes they can't even get 3 words back if they're bad.
You have to say you have to do it 3 times. You use the same words.
Yeah, you use the same words. If they just like they're getting confused with it, you can switch to an alternative word list, but you try and be consistent once you stick with that set of words the whole time. And then the next time you assess them when they come back later in the week, then you need to pick a new list of words, otherwise they'll have remembered possibly from first time. So
as you do each trial, do they get better or do they get worse? Which is
there is no set pattern. Again, like there isn't a known, a known pattern of improvement or decline. I think if you suspect that they're having problems with attention and concentration, and they start forgetting words, then you can think that maybe that's attention concentration rather than short-term memory. If they get all 5 and they start forgetting them as you go, for example, so it's a bit of a judgment call on your part as to what's the significance of this. And down here you've got months in reverse order. I prefer, so I work with uni students and a lot of them will have good maths ability, so I prefer to use serial sevens for concentration. So you say, I need you to subtract 7 from 100 and continue to subtract until you get to 2, which is the lowest number, and as fast as you can. So, you've got engineering students taking over a minute to do that. That's clearly not right. Everything else you do, they're 5 minutes. And they usually walk out feeling really dumb, but it's the kind of thing that, well, you've got to find the sense in the text. You can make sense. Balance examination, it's not this actually, it's not as easy as it looks. You've got to do, there's 2 different ways of doing it. You can do tandem walking, set distance of 3 meters, which is hard because you've got to time it, or you can do static tests where they stand either on 2 legs, tandem gait with 1 foot in front of the other, the kicking leg in front of their non-dominant leg, and single leg. So, and they've got to close their eyes, hands on the hips. You count the number of errors they make. And actually, I think up to 4 errors is acceptable, but yeah, you do all 3 of those. All right. And any other questions for John or myself on concussion testing?
What's it like being under the duress of a managerial team and admitting a player's fit to return to play?
Yeah, do you want me to start?
We would have had it already with you.
Oh yeah, I've had a more recent experience. So you're under duress to make decisions, especially in a game where the player has no head in, or a substitution interchange like in AFL, where a player can have an obvious head injury and can get them off for the time, and someone else goes on for them, it's no issue, and you've got time to assess them. In rugby union at the suburban level, there is a head in, so you run over to the athlete, you have your walkie-talkie with you, and there may be days, they may be struggling to keep up with play, they might be on one knee feeling like vomiting, and all of those things tell me straight away that they're concussed. There's absolutely no doubt in your head. The difficulty is being seen to assess them in a standardised way, because when the coach says to you, so what evidence was that they were concussed, you could later you can tell them that. It's really a difficult question to say, it's my judgment. In my medical opinion, they're concussed. And more, I think coaches want to challenge that and managers want to challenge that. I don't know how you feel, John, but I think you've got to just play the game, assess them. I get them off if there's any concern. And in rugby union, when they're off, they can't come back on. So it is a big decision, and I make it obvious that I have made every effort to give them an opportunity to continue to play if they're not concussed. Yeah, these guys are 19. They're not wrecking their career and letting them run around brain injured for a coach.
Yeah, it should be pretty easy at that level, even though it's not. In that there's certainly a feeling that at any level of sport that coaches are aware that if they have a winning season, they retain their job the next year. If they have a losing season, they will get the sack, and that even applies at the under 19 level. So, people talk in cliches in sport all the time, but it's just like, the coach didn't have the dressing room, so we need to get someone who's got because the players don't like saying, we were a crap team, just didn't play well. They sort of say, I don't think we've got coached very well, that's why we came through last this year, and then they say, we'll get a new coach. So coaches are aware of that, so the pressure on coaching staff at any level is high to win, and so they can still harass a doctor at low levels of the game. It's not necessarily at the fully professional level, but it's something that affects my ability to. I had a very fortunate time in working with respect to concussion. For the most part, I was at the Roosters for 16 years, and the first year I was there, I got absolutely overruled by a coach in a final. There's a player who is now an NRL head coach who was playing and we're playing a final in Melbourne, and he was so concussed he thought we were still in Sydney. And I said, I said at half time, he's got to come off. He's got bad concussion, and the coach said he's not coming off. He's staying on, and that was 1998, and there was there's no chief medical officer there. There was no one to report that to. It was just a matter of, well, we got away with it, and so it's just you just kept going on. But for the most part, I did what most doctors would have done in the majority of that time when there was no concussion rule, where I felt my role was to say that any concussion in a non-critical time of the game has to come off, and then a so-called mild concussion in a critical time of the game, a critical player, I was happy to let them continue and keep an eye on them, and the severe ones, no matter what I bring. So someone who didn't know which city they were in, or who they were playing, or had been knocked out for 20 seconds, or a player who had 3 concussions earlier in the season, they were all coming off. But I was letting 50% of what I would call minor concussions keep going because it was critical. They wanted to stay on, and we were keeping an eye on them. And the fact that I was letting that 50% on meant that I could sort of say to the coaching staff, look, I'm giving you a little bit of leeway here, but then when I do come and say this guy's going to come off, you're going to listen to me, and that sort of worked quite well. Where it got difficult was Zurich guidelines, which are necessarily guidelines, came out and said, same day you shouldn't return to your concussion diagnosis, you shouldn't continue to play, shouldn't return, and then you're in a scenario where the milder cases where it's harder to work out whether they're concussed or not are really difficult. But I even think that in the football competitions at the moment, there would definitely be cases still of doctors getting overruled, and then it's an extremely difficult ethical scenario where you've got to decide if a coach is actually, you said this player's concussed has come off, the coach has just overruled and said to the player, do you want to come back on and stay on? The player says yes, and the coach says, well, off you go. As a doctor, if you're going to report your team to the chief medical officer, you're possibly going to make your position untenable. Either the coach gets the sack or you get the sack. And so a lot of people would be biting their tongue still and living in that very difficult scenario. And because I believe that is occurring, I think inevitably, much as some people hate the idea that there will be probably in all of the football codes independent doctors making decisions. So I say 10 doctors will look after all the other injuries and they can weigh up with the player. And a player can give informed consent. If they've got a torn medial meniscus in their knee, you can sit down and say, look, this one might need surgery, etc. It's up to you, etc. Legally, you can't give informed consent to start concussed. So if there's no defence from a doctor's point of view to say that I wanted I wanted the player to come off, but then he told me he wanted to go back on, and I gave him his autonomy. In a legal sense, they will say he had no autonomy. He's not he's a robot. He's not fully able to assess the risks with limited mental capacity. So again, there will be a lawsuit one day, which is specific to a doctor saying a player should come off, and the coach saying, I'm overruling and sending him back on, and then something bad happens, and then the lawsuit will be all about, well, how much should the doctor have, jumped up and down and waved red flags on the sideline to get the decision returned, versus how much did the coach sort of get a direct sort of command from the doctor wasn't going to come back on. But again, as I said, independent doctors will solve it, and we will just have more and more controversies in NRL, AFL, soccer. And it's funny enough, soccer is sort of meant to have fewer head injuries than it probably does when you lay up absolute numbers. But some of the World Cup incidents last time were some of the absolute worst you've seen. I mean, there's bad ones in every part. There's there were the Uruguayan and the German, and the Uruguayan one where the coach just came down on the ground, or the manager just came down and just fingered the player and sent him back on, and the doctor sort of said, no, he can't play, he's off, and then managers came down and pushed him back on, he went back on. There was one that hardly I talked about in the World Cup where a Russian trainer or someone gave smelling salts in the World Cup for a player on the sideline, he went back on, and that actually didn't even get commented on. It was happening in the World Cup, last World Cup in Brazil. And the Germans was almost hitting, I think, in the first half, and then sort of sent back on, and then came off at half time, having had other players complaining that he didn't know where he was on the pitch. So the controversies aren't going to go away because the coaches know that we're as doctors worried about the risk which we can't quantify. What's the risk of someone who keeps playing for a concussion during their football career? What's the risk that they're going to get premature neurodegenerative conditions like premature Alzheimer's or motor neuron disease or Parkinson's disease in their 50s? We know that their risk is increased. What's the chances? We're talking about a 1 in sort of 30 or a 1 in 50 risk of those sorts of things happening, and we don't want people to be subjected to that. So we say they've got to come off. But the risk of a coach of not holding their job until the next season in most football competitions is about 1 in 4. So the idea that they're going to happily accept the decision that they're going to lose their best player and can't win the game because their best player's off the field, that's not going to happen either. And ultimately, what we need, and it's a sad thing in a way, but it's a maturity thing that the whole of society's got to wake up to. That speaking of brain damage, when a traditional fan goes to a game, they sort of, their IQ might drop from 140 to about 47 for the purposes of that game, where they don't care whether, they wouldn't care if one of their players took out an AK-47 and shot someone in opposition. They would say, oh, that's good because now we can win. It's like, we committed murder, so it's like, oh, it doesn't matter, at least we're going to win the game. And fans have that attitude, they can talk out of game time, things like diving is terrible, things like, faking injuries terrible. If you're the quarterback for the New England Patriots, letting down the football so that you can make a pass more regularly, it's terrible, cheating, etc., etc. If your team does it on match day, gets away with it, it's like, we won, I don't care. There was a great article I read in soccer, or English Premier League when I was over there last year, where someone wrote an editorial saying, everyone hates diving in football, but it's never going to end as long as the home team, as soon as the striker in the penalty box on no contact takes a dive, the crowd screams for the penalty and just roars at the referee until the penalty is awarded. And then when it gets awarded, they just have this massive cheer. The replay will come up, no contact, the guy just took a massive dive. They won't care. It'd be like, great, kick the goal, win 1-0, we don't care. And it's the morality of win at all costs. Comes very much from the fans, and the coach is just as the fans' representative of that. So with that attitude, independent doctors are a way of getting around it. But ultimately, we've got to educate the fans that it is good to be fanatical about your team, but you actually have to have a little bit of a part of you that says there's a line that your team can't go over. But it's very hard to find those lines that anyone is upset that their team's crossed. You look at Essendon and Cronulla with using peptides, and people who aren't on those teams to say it's an outrage, throw the book at them, suspend them all for 10 years, etc., etc., etc. But if you're a fan of Essendon or Cronulla, it's very, they all think we did nothing wrong. You haven't caught us. There's no smoking gun. What's wrong with what we did? It's not. They don't have a morality. That's how they have. We don't want our players to be suspended because that'll make it hard for us to win this year's comp. So we must be innocent because we can't lose all these guys because then how are we going to win next year's comp? And that's the only thing that matters. So that's the problem in terms of dealing with concussion, that you 100% as a doctor can't be a fan. You can want your team to win. You can completely divorce yourself from that, and you actually have to go into a season knowing what would happen if the coach or the manager outright overruled me. Where do I stand? And some people may say, it's an area where I wouldn't report it on tour in my career, sacrifice my career over a matter of principle. Other people would say, look, I'm doing football for the experience, but I can live with being a little bit of a martyr and reporting my team and getting the coach's ass kicked, but it probably meant resigning and standing down. And we've already had one of the Parramatta doctors this year allegedly quit after 4 weeks because of getting paid over concussion, and it was more the other way, that the doctor sort of seemed to say, well, if I'm having my medical integrity questioned by the media, I don't want to work here. But it could easily have been, and I have, do you have any inside knowledge on that one or not? Yeah. It could easily have been that the doctor did get overruled, and the clubs can't say, we're sacking you because we overruled you and you didn't, you're going to bleed about it. This would be like if you're resigning with a payout or whatever. If that was the case, I've got no idea. But foreseeably, again, if a coach had overruled the doctor and the doctor was going to go public, it'd be in the club's interest to say to the doctor, look, you just do the honourable thing and resign, and we'll give you a big payout to stay quiet. And so the ethics are unbelievable. And as I said, the fact that these sort of things are probably going on, they can't get going on like this to infinity. Eventually, we'll probably get independent doctors for those private comps.
Yeah, the real difficulty with the doctor is that everyone else in the clubs go. The physios, the coaches, right hand man. I'll get this guy back, we'll get him back into play, and not only for concussion, but for other issues as well, rib fractures and things that people shouldn't play with. You're the only stop signal. So that's one thing we've got to get used to. Is as John alluded to, is picking the battles and knowing when to stand on principle and defend and represent the players and do the right thing by them, and knowing when to give a little bit of slack so that you'll give them very serious decisions.
Nothing about concussion in terms of when has it to the player to come off the concussion. It is a difficult diagnosis in its milder forms, and you can, from reading, those of you who have read about the ASADA trial and have any interest in law, you have the criminal standard of proof, which is beyond reasonable doubt, and the civil standard of proof, which is chance of probability. So civil standard of proof is sort of meant to be 51-49, you award a judgment in a lawsuit case, and a criminal has got to be beyond reasonable doubt. And I don't give percentages, but 95% gets tossed around. We're 95% sure he murdered the guy, so he's going to jail. But if we're only 80% sure he's going to get off because there's a reasonable doubt with that 20%. In the ASADA case with Essendon at the moment, they have this very vague standard, which is in between the two, called comfortably satisfied, which is you're comfortably satisfied that they used the banned drug, and if you have to put a percentage on that, is that 75%? You think that 75% likely that they took a banned drug, therefore we're going to ping them. It's not meant to be 95, but it's not meant to be as low as 50. And concussions like this at its mildest forms, there's ones where you see a video and a guy hits the deck and he's out cold and starts spitting, and you can say beyond reasonable doubt concussed. So if anyone reversed that and sent it back on, they were kidding themselves, and there's no way you can look at that and come up with an explanation other than concussed. But the player who's got the headache, got a big whack across the face, got a bit of a headache, bit vague, bit of a vacant stare, but can answer the questions, knows who we're playing, knows. And some people might say that's 50-50, he's concussed, and I'm not going to try and pull off all the 50-50s, or I'm going to not retain my spot in the team. I can give him benefit of the doubt that if he wants to stay on, letting him stay on. But someone else and again, you might be sort of have that at professional level where you're comfortable. That's a 50-50, and I don't want to fight on every front at professional level. But if you're looking after a schoolboy Year 9 game, that player comes off because you don't give them any leeway to say it would be unconscionable to sort of have a school kid stay on when really it's probably 60-40 these cuts, and if 60-40 cuts in Year 9 is coming off.
I think you've got a reasonable justification for what you're doing, for making the decision that you make. thinks defensible. You know, like I've worked with doctors who have said, oh, well, the player's holding his head, so clearly he's not concussed because he's aware of his head. And I'm not saying, well, I disagree at the time, but that's your decision. So long as we've documented that you've made the decision, right? Just you got to be a little bit careful. Everyone's medical judgment is their own medical judgment. So I thought we might just quickly move on to going back to basic life support. Just briefly, show a couple of cases related to sport. Again, I've just stolen all this material from IOC content, so John will have seen a lot of this. With your assessment of a critically injured or ill player, there's two very distinct streams of management. And it's easy to get caught up in the first one, which is when they're alive. But you need to clearly distinguish the alive patient from the dead patient. And sometimes it's actually not as easy as it sounds. I want to show you examples of where it looks a bit borderline and you're not sure whether or not there's signs of life. And you hear about your vital signs and all of that sort of thing, but you don't measure that. You look for if they're breathing and you look for and you feel for pulse. But I'll go through this just really briefly. So I run ALS courses for the Australian Resuscitation Council, and we have anaesthetists, GPs, interns, residents, advanced paramedics come to the course, and we've had to fail anaesthetists on that course, and they've got incredible knowledge. They're really, very intellectual people, but they failed to respond to cues, which is to say they will be trying to assess the patient's airway when they're dead. When a patient's dead, you flip over to this mode, which is, there are probably some reversible causes that we need to think about, but right now they need cardiac output and they need someone pressing on the chest, and as soon as possible, pads on their chest and the possibility of defibrillation. So, you guys get to play with the defibrillator models at all, or training DJs? Yeah, so that if you haven't done a first aid course, that should be part of the first aid course that you do, is playing around with the defib. There'll be automatic defibs. The disadvantage of the automatic defib is that when you get the pads on and you're ready, you've got someone pressing on the chest, it says, please step away from the patient, and everyone steps away. And no one's pressing on the chest the whole time. And then it says, analyze the rhythm. And about, 20 seconds later, it will tell you shock advised or shock not advised, and it'll tell you step away from the patient again. And about a minute later, you're all standing there going, can we touch the patient? Or what's going on? So you lose valuable cardiac output that you took all that time to build up. So ideally, you should have a manual defibrillator if you are able to invest in one. I'm a big fan of every doctor being in possession of the defibrillator because it's the one thing that massively improves survival from cardiac arrest. And cardiac arrest is the end cause of death in that pathway. When you become interns, you'll get used to filling out your cause of death form, and you'll get right down to the bottom of patient pneumonia led to dehydration, and then the bottom cause cardiac arrest. And so that's really, if you can stop them on that end pathway in a healthy person, especially, then that's really a good thing. But I want you to just, for now, realise that the CPR that you're doing out there is vitally, it's pivoting on the fact that you recognise that they're dead in the first place and aren't trying to manage their airway, for example. Okay. So, what I sort of want to make a point here was this is YouTube clips. Yeah. So this was a Cameroonian soccer player who died about 10 years ago. Yes, Mark, big photo. So he collapsed by playing. This is him. I'll just show you a short video. You can see the trainer come over, hold his head up off the ground. He's just collapsed without any warning, away from the play. No one near him. And then someone's gone over. I don't know what they're doing, whether they're trying to feel a pulse or move his move his chin and the chin cup to open his airway. But now they're sort of holding his head around. So sorry about poor resolution, but this shows he just collapses in the middle of nowhere. And you can see the sort of white eyes, that's not a good sign. He's not breathing normally, and he didn't, well, he had a cardiac arrest and he died later to be found to have hypertrophic cardiomyopathy, which is something that we're beginning to try to screen for in athletes. But the point is that the efforts to resuscitate him were fairly delayed in this case. I'm not exactly sure how long. I think it was several minutes before the defibrillator attempt was given to him. And yeah, we look at the gold standard, being able to get pads on and shock someone within 2 minutes of arrest. That significantly improves survival. Do you know how much survival goes down for every minute delay on defibrillation? Exactly right. Yeah. So 10% is a rough figure. So 7 minutes later, you're left with a few percent of survival. And not all cardiac arrest is reversible with a shock, but
Now you broke that so when you see a guy's alive, you never call CPR.
you avoid it if they're awake and there's no and there's signs of life, then there's no need to perform CPR.
So for this guy, you see he's awake, but
No, he's not awake. He's not conscious.
oh right, okay, that's how you come there.
No, I don't. But I'll show you. I'll go into the definition of arrested. It's not technically dead, because dead is actually fine. That's getting philosophical. No, you have to. The point is that recognition of cardiac arrest is not looking at them. There's a process by which you recognise that, and we're not really. I'm not doing a practical session on that today, but I'll just sort of. I think I've got another slide on it, so. On the next slide. But the point I'm making here is that people can overthink the process of whether or not they're alive and they've got a problem that you can reverse, so they don't arrest, or they've actually arrested already. And the way to recognise cardiac arrest is get down, ear on their mouth, listen to whether they've got normal breathing or just gasps, and put your fingers on their carotid pulse and look down their chest. If their chest wall's not moving, you can't hear normal breath and you can't feel the pulse. If in doubt, start CPR. But no longer than 10 seconds is recommended for that whole process. So if you go through that motion, ear to their mouth, looking down their chest, finger on their carotid pulse, and you're in doubt, you haven't done any harm really, except maybe pumping the cardiac output a little bit. If they push you off and say, I'm all right, what are you doing?
And you've got to reassess it too, because in this one, he did take a couple of agonal rests at the start, and had potentially someone's got to him and thought, oh, he's breathing, he's okay, and then his heart stopped 20 seconds later, and maybe the person in the field in charge is saying, oh no, he's definitely been breathing, and maybe they checked his pulse, and he did have a pulse for the first 15 seconds of going down, but then he lost his pulse and they're not re-checking, and they bundled him off on a stretcher it took 2 or 3 minutes to get him off the ground, and then they started assessing him, but he'd actually been arrested for 2 or 3 minutes without anyone having to recheck the pulse and recheck.
So keep coming back, and I guess that's the key is you're not doing any harm if you do start CPR, and don't stop the CPR if in doubt until there's really good signs of life. They're pushing you off the breathing, because until you've got a monitor on them that you can actually tell them that they're alive with signs of life and they've got a beating heart, you shouldn't stop CPR. So start it and don't stop it until you've got help and a monitor that actually can tell you. But these guys have such amazing reserve that you'll even see that they can be combative, and they're going in and out of arrest, their hearts, they're going into VF, and there's pulses VF, and it's VF, and they're pushing people away, and they're having a seizure from cerebral anoxia, but they're just amazing athletes. That's what all of this reserve, so you've got to reassess.
The other thing, as you probably learning from practices, is that CPR is evolving to CR, as in they're sort of seeing that the amount of compressions that you do is 95% of the outcome, and don't let breathing get in the way of compression. So in other words, breathing is a bonus, but you're getting a little bit of pumping air just with the chest compressions as well. So you're sucking a bit of air in and out, So if you've got a single person, maybe even don't do breathing at all, and don't stop for very long for person two. If you've got two people and one person's going to do chest, the other's going to do breathing, person two, you can get about 5 seconds to do 1 or 2 breaths, but the most important thing is don't just keep going with the cardiac, and if in doubt, brush off the pulmonary resuscitation and just go cardiac, and you're still more likely to get a result than if if you're stuffing around with trying to get the airway right, so you can do a breathing or whatever, and you stop the cardiac, that you lose on that basis.
Exactly. So you're losing everything that builds up. Have you guys seen agonal breathing before? Is anyone aware of what that is? Can anyone tell me what agonal breathing is?
Deep gasping breaths that happens when we're red. Just oxygenation.
And do you know why they're gasping and doing that? It's just brainstem reflexes that are left over, like they're essentially losing a lot of cerebral confusion, but the brainstem still got some reflexes that are running through. So that it's sort of the remnants of normal breathing. It's not quite normal. So this is by my rescue. Do we have any sound? Probably not. It doesn't matter. Oh, you just need to see it anyway. So these guys, Bondi Rescue, posing for some photos. The young Japanese guy is found as floating in shallow water. So here's their management. This will just take a couple of minutes to do it. So I want you to particularly look at his breathing pattern. The only exception to that CPR rule is in drownings, because oxygenation is probably a little bit more important. We've got So you got a defib on site within 2 minutes of him getting to him. He started CPR already. We identified that even though there was some risks going on there, there's no pulse, but that was a quick. You've got to make that decision quickly and not faff about. So they got the pads on in 10 seconds. And then there's a shock. This is the only problem. Like normally you just go straight back on, keep pressing, yeah? When I say normally, it's when you've got a manual machine where you can choose whether or not to shock based on what the rule is. So I had another feel, mucking around for a little bit longer. So it's probably a little bit slow, that rate of compression. It's going to be very picky, but the depth you can see is quite good. And we talked about position of compressions here. So middle of the chest. Don't muck around measuring, just go straight in the middle of the chest. It's usually the lower half of the sternum that gets you through. All right, so you can see him doing his agonal breathing. This is a well-conducted arrest situation. This was a Tottenham player who had an arrest that a Bolton, sorry. He was there we go. You can see him having it almost looks like it's spitting. He's face down, which is very difficult. Physio's trying to roll him, he's fighting him. And it was a very drawn out arrest. It took there were 4 rescuers that came by, and one of the doctors started CPR probably within 10 seconds of arriving at the scene. You can see just here, if I just pause it, you can see sort of back here, you don't get a great view of one of the doctors there, but you've got the paramedics all around, and you'll see them popping up and down on the chest there. I think he received a shock, within a couple of minutes. it was 78 minutes that the resuscitation attempts went for, and he's actually alive and pretty well now without significant neurological disability. So it was a success from that point of view. I don't think he's playing soccer anymore. But yes, he's it was a bit of a terrible deal for everyone there. And you can see the impressions going on there. Well conducted, everyone knew you could see everyone knew their roles, good decisions were made, and I guess in that situation, the best outcome you can sort of hope for is to sustain life. You don't have advanced, resuscitation instruments on them necessarily. You're out in the middle of public scrutiny, extremely testing situation. So I just wanted to point out with that they recognised the arrest very quickly, started CPR, and the pads came on very quickly. This is one of the fastest returns from the dead that you'll see. This is a Dutch soccer player. There he goes, there's a shock. So he had an internal defibrillator implanted. So he must have known that he had a and he actually requested to stay on the field. So to summarise, you're as a doctor at the field, wherever it is, whether it's schoolboy rugby or professional level, you're expected to know what to do at all times, and there is a lot of pressure on your medical expertise. Even if you haven't intubated somebody in 10 years, you've got to know how to manage an airway the best way you can, do things that are within your skill range. And that, it certainly comes with public scrutiny. You've got people watching you, watching their beloved athletes, or family. So you've got to be always prepared for the worst, but obviously hoping for the best. Point out the clear difference between alive and dead patients. Recognise arrest and start CPR if in doubt, and just get going. Work within the team, know your role, whether you're a team leader or you're going to work on depressions or you're going to look after the airway, know your role, where you fit in, and actually practice with your team. That's, having an emergency plan is the rule, not the exception in sports medicine. You have to be prepared for the worst. So this is something I just thought I'd give a quick plug to, and I am a proponent of this as well. So Professor Chris Ansari, he's a genetic heart diseases cardiologist specialist at RPA, and his petition that he's trying to get everyone to sign, you guys can probably log on and sign up for this as well, is to get defibrillators in our schools. I think I worked out the cost to be something like, it would only be about between $15 and $20 million. Like when you look at how much it costs to build one school, or get a new line of buses or trains, $15 to $20 million to have trained staff who can use a defibrillator in every school is peanuts. You've got the potential to save a lot of lives and a lot of harm there. So when you have come of age, these are courses I strongly recommend. I think if you can do it as a medical student still, I'm not sure, but I haven't seen any medical students on any courses. The youngest I've seen is intern, but definitely get into it because it will just build your confidence and make you appreciate the reversible causes of arrest. So you've got somewhere to go once you've started the CPR, you feel you can manage the situation. Do you have any comments or things you want to clarify?
Yeah, one innovation that we're moving towards, and it before too long will become routine, analogous to most of you been inside an operating theatre yet, so a lot of you will have, maybe depending on what you're in. But yeah, in operating theatres now, it's just accepted that you don't start an operation without what's called a surgical timeout. So in other words, they have to say, who's the patient? We've got a band on the proof. This is definitely the patient. We're definitely operating on the left knee or the right knee, and we're anaesthetist is ready. Got all the check all the equipment, etc. That all takes about 40 seconds, but you just go through, just make sure that 100% everything's cut off. Sporting events, we will get to the point where you start a sporting event in the same fashion. In other words, if there's a defib at the ground, people at the ground need to know where the defib is, because it's one of the, I mean, you can have that petition about, you know, you can have to train staff and you can have a defib there, and if the defib's locked away in the cupboard and you can't open it, then basically it's useless, and, you know, and also medico-legally indefensible if someone dies, didn't get defib because you couldn't open the locked cupboard. So we will actually, again, there'll be an element of society that will say this is going to ruin sport, it's not going to be fun anymore, we have to sort of prepare for death before we start a game. But we all expect that if we're going to get on a plane, we don't care whether it's, you know, Jetstar or Tiger or the lowest of the low, they're all doing a safety check before they get on. You know, like it's just like you must run, you know.
And the risk of death is probably similar.
It's probably a legitimate comparison actually, because it's the risk of death, or interestingly, the risk of death in airline crashes, because of that sort of safety mentality of the aircraft industry, probably came in, you know, mid-60s, and you look at the, you know, number of passenger losses by death by decade, and it just drops down every year, so every decade. So in other words, planes are getting safer and safer all the time because they have the attitude of safety is paramount. And even though it's only, you know, 3 to 1 million, you know, planes come down, you know, they're having the attitude of 3 million is unacceptable. We sort of have to do that with sport a bit, as in, rather than have this attitude of, oh, freak accident, you know, nothing could be done, etc. If we're moving towards saying, well, hang on a second, that was at an amateur level where the guy dropped and there wasn't a defib and there wasn't anyone who was first aid trained, or there was someone who was first aid trained, but they were off buying a coffee and no one, you know, and it happens all the time at low level sport. It's like, we you know, that sort of cascade of treating this as something where a death would be an unacceptable outcome, just as we think of plane crashes are an unacceptable outcome no matter what. We sort of have to move towards that, of saying, well, have a timeout before the sporting event starts to say, do we have defib here? Who's first aid trained? First aid person watching the game. If there's a doctor there, the doctor's watching the game. We know what all the equipment is. We know what the signals are to stop the game if something bad happens. And that will, we're doing that at the top professional level now, but that will evolve to go down to all levels. And an analogous example, it doesn't always apply, but we just saw an example from the surf. If you are an experienced surfer, they do have a little bit more of a mentality. Not all of them, some of them are very gung-ho, but they have a mentality of you respect the sea, as in you shouldn't surf by yourself, because if there's a dangerous rip and you get knocked out or whatever, if you get knocked unconscious in the surf, by yourself, you're dead. Surfing with someone, they save your life, simple as that. So therefore, you know, respect it as a place, and we've got to respect the sporting venues as a place where these sort of things can happen. The problem is something that's a 1 in 200,000 occurrence on any given day seems so low to not worry about, but you expect, as I said, you expect Jetstar pilots to be worried about something that's less than 1 in 200,000 when you're getting on that plane. And so that's a bit of a culture change. We're going to run this one.
I wish we had sound.
You've got to have sound. Can we get sound up here? Because you've got to have sound. What's the thing that
IT guy. We'll see what we can do. But we'll just sound coming out. Let's come out down here. The mic definitely works. I know the mic, this works, so we can just put the mic right next to the speaker. Who knows? The Sports Medicine Society.
Visual way.
Can we just get this fixed? Where's it coming?
Yeah, I have no idea where it's at. Like,
Well, I need to get this down, it's not a word.
We can post up the links after.
Get this up when you go home, from the park, it's Scott Sterling, you haven't seen it, it's, goalkeeper gets hit in the head about 5 times during the penalty shootout.
He's so sad.
Only you could have said that.
He's so devastated.
Is this real? Is this just a mock up? Yeah, yeah. Yeah. Yeah.
Right? I don't know what's
What's the monster from
Oh, sorry. How are we going time-wise? Do you want to keep going or finish up?
Yeah, bedtime.
Yeah, I haven't done enough yet. It's all good there.
Alright, well, in that case, just like to hand out some certificates of appreciation, firstly for Dave, again, for helping us out. Pleasure. Thank you. And John.
Actually, I'll finish off with one key so wonderful thing, just as a bit of encouragement to you all, it's great to, I remember when I went through medical schools, sports medicine didn't really exist, and there was definitely never any lectures on it, no one ever talked about it. I did manage to do in final medicine an elective in it, but when I wanted to get into sports medicine training, it was still almost just a non-existent specialty, and it's boomed massively in the last 20 years, so it was a great decision to go into it. At the moment, all the focus is on the sports side of it, which we've had, but the thing that will boom in the time of your careers will be the exercise medicine side of it, because exercise is the miracle pill. Exercise is better than just about it, other than not smoking, which is about par. With exercise reduces heart disease, stroke, diabetes, cancers, most cancers, osteoporosis, depression, etc., etc. So it's a mass, and it reduces their risk and also improves survival from them. So exercise medicine will be the big new area of expansion, because the idea of specialist doctors who can get people to increase their exercise and therefore improve their health, that will become a massive mainstream part. It's still only a very small part of we're College of Sports and Exercise Medicine, but the sports side of it's here and the exercise here, and it'll expand so the exercise eventually gets bigger.
And no one owns exercise. I mean, it's every specialty, but they just don't know how to prescribe as well as we do. And I think, we work with endocrinologists to direct diabetes and polycystic ovaries. We work with orthopedic surgeons, and all of them recognise and where to progress as a specialty in that way. If they recognise us as the go-to, then that's fantastic, because you're suddenly becoming the prescriber of exercise as well. So a really important thing to get around.
Yeah, so the elite sport, it will stay big and important, but in a specialty, it will go from being half the specialty at the moment, sort of a focus on elite sport, and it'll be 10% of the specialty when you guys if you want to get into sports and exercise medicine, it will be 10% of the specialty, and the big thing that will be booming will be the exercise side of it.
So we do have a whole bunch of things outside, so you're more than welcome to come and ease yourselves on there.
And I'll leave these outside as well. These are just, if you didn't grab one of the discounted training first aid courses from Airway, they'll be outside.
Oh yeah. Sorry, the last 3 minutes. Sorry, I forgot to announce this. They are here. They are here. So last 3. So yeah, so guys, last 3 are Joanna Fong, Kishan Aya. There we go. Oh, that's fine. And Theophila Hayes. No? Are these guys here? Alright, sweet. Just come chat. Alright, nice one. Hello! So I'm just gonna, because I need to pull this. It's easy. It's So I'll just send it to Don and he'll sort that out for you. No worries. Hope you had a good time. No, but we are now. Basically because it's like
What is
yes,
Do you want to go in here or?
bring it outside. Can we bring it outside? I did not.
Simon's at medical view.
Oh.
Yeah, that's right. Just. On research. Easy. Send me an email. You know what? It's just present in Facebook us, right? Yeah. I don't know. So what do you uni? So are you kind of asking whether you can do it? Oh yeah. And I think once I
Should we turn it off?